Good afternoon, everyone. I'm a little bit nervous. So basically, my topic will not be the same like all of you. I don't know, is it I just the wrong or not, but I believe that this will be like the good choices to be here with you. So basically, my topic is about the disrupting healthcare services in Indonesia. I start this research project is actually since 2017 when I did another research with the same one like this one, but it's more about the universal healthcare in my hometown in Yogyakarta. Yep. So what is actually becoming the hot issues in Indonesian health issues right now is that we just changed our health national insurance since 2014 to be the new one integrated to be social security system in our country called BPJS, or Social Security Administrator for Health. And since the birth of this national health insurance schemes or program, it has been accumulated until today in 5 years, like 22 trillion deficit for the government is because of the burden they carry on. So if we looking back for the background of our Indonesian healthcare system is that we actually mixing the two system of the healthcare in the world, that is like the Bismarckian system, which is from the German system, and the Beveridge system is from the UK system. So Bismarckian system is based primarily on social insurance contributions. So people will get the health services based on their ability to pay, and they pay as the contributors. And the Beveridge system is more lying on taxes, where the people will get free all the health services after they pay maybe like the higher taxes for the government. So in those kind of system, it's quite different. In this market system, like there's no distribution between various income groups, just because they pay the services based on what they pay for themselves. So they just the health insurance based what they need. And in the Beveridge system, like there will be like redistributions. But in the Indonesian case, we have like the mixture healthcare system that the governments actually try to implement the Bismarckian system that the individual or the informal sector or the formal sector one can pay the healthcare system through the payment process in each month, and the government in another part, the government also help the poor people who are actually below poverty line through the below poverty line schemes, what we call it as bantuan iuran bulanan. So it's actually as a part of how the government distributed the cross funding in the healthcare issues. So this is what I told before. Since the birth of the BPJS since 2014, because we changed from the health insurance or asuransi kesehatan, and then changed to the new one as we call it Social Security Administrator for Health or BPJS Kesehatan, it accumulated like 32.8 trillion. This data I got like from the Ministry of Health Indonesia. The growing deficit of Indonesian healthcare becoming one of the serious problem is because the first is like there is a mismanagement on financial budgeting, and Indonesia is actually have like we can say if compared to the other countries, like for example South Korea and also other countries, we have I think like still in the lower or under price of insurance contributions. We have like actually we have 4th tier, but it's actually the actual tier, because the 4th tier is actually the below poverty line schemes that the government funding for the poor people. So this is the 1st tier, 2nd tier, and 3rd tier. So how actually this kind of tier classes is actually well, we don't have any like we don't have any specific like indicator to choose whether or not we can get like the tier 2 or just because our salary in that kind of rate. But we can choose our own preference, what we want to take in this kind of tier classification, not based on our salary. And because of the underprices of this kind of insurance, in the 1st of January 2020, the government just raised like 100% of health insurance to be, for example, like tier 1 from it's also 80,000 rupees. It means like 8,000 bucks to be like 16,000 bucks, like that. Another part is about the informal contributors. Is only there are 54% who are actively contributed to the insurance payment, and the list is actually not active or passive. They will pay for the insurance when they get sick, but when they have healthy, they will not they will stop the payment. This is actually the problem. But the utility of this kind of insurance is actually high. So it will be the burden of the government. In another part is also about the inefficient medical data and clinical pathway management. We have actually, we call it the INA-CBG system, Indonesian case-based system. INA-CBG is actually the indicator to assess the financial needs that the health services actually needs based on the services that the medical expert of the health service providers actually have. But just because of the problem of that kind of burden every year, the government always changes the procedures of the INA-CBGs. For example, if you want to get one services on the healthcare just because you have like cancer, with this kind of scheme in the first year, but in the second year we'll have another scheme in the first year. So like, for example, you usually actually getting the medicines like only a week, but in the next year you will have like different scheme to get like your medicines in this context. So in this kind of situations, I'm trying to figure out what is the opportunity on this kind of context. How the technology can critically resolving the current problems on Indonesia healthcare system, because it is very important. The lack of data management and the financial budgeting that the government has, it has like it actually has like make the government burdening their financial budget in the national budget. So this is actually what I do. I did my 4 days research program in the show is actually to comparing how actually the systems in South Korea and also how the system in other countries, because in this context I met with 4 research persons, 4 informants. The first is actually the Hyung Young. She is Director General of the Korea Foundation for International Healthcare. And also there was Satyaki. He is an Indian foreigner who living in Seoul and working in Seoul also. And Sang Kim, she is a director of Health Policy Center, the People's Health Institute. And the last one is actually the Funo. Funo is a startup, AI-based medical diagnostic startup that's focusing on like medical solutions. So I got a lot of discussions. In my perspective, when I met those kind of people, those 4 people is actually quite different. Because in my perspective, okay, I'm just like another Indonesian. I believe in the universal healthcare. It should be like implemented in the way that we can help the people, or healthcare should be affordable for all, regardless their ability to pay. But in this kind of context, when I talk to those 4, they have like different views, thinking that actually disrupting my way to understand that the idea of like health insurance should be very rational somehow, but somehow it's also political in the context of the national situations like Indonesia. They believe that national health insurance should not be like free at all. Okay, in one part I believe on that, but in one part I think this is actually also our responsibility to help the people who are actually in the poverty line. So my proposed solutions is actually a little bit like disrupting the conditions right now, because we have to adapt to the current conditions in the technological advancement. What I meant like is actually personalized health intelligence. So what is personalized health intelligence? It's actually like a data management, it's like personal data management that you can input by yourself in your phone. Okay, I am actually, IT might be out of my league, but I have like certain understandable about this kind of systems when I was like discussing and joining youth organization that also working on this kind of technological advancement and discussions. So how it works, personalized health intelligence will be like becoming the preventions. It will be like daily habits computational data systems, because like we as a younger generation, okay, the changing lifestyle that we have right now made us like don't really understand about our healthiness, like our drinking habit, our smoking habit, or our eating habits. That will be actually become the worst case if we don't check up our itself before we get sick. Like in Indonesia, maybe like the medical checkup is not like normally we do, because it's actually the high cost. It costs like maybe like more than like 2 million rupiahs. It's like 20 bucks, more than 20 bucks like that. And it's actually very important to do that. So through this kind of mechanism or the schemes, we can actually input our data, daily data, what we eat and what we drink every day, what our habit every day through this kind of system. And the second one is as the assessment tool, today is the daily medical recording and projected services. So we can actually, after we collecting the data of our daily habits, we can assess what is the projected or the possibility that the disease or the sickness that we get in the future, or the healthiness of ourselves in the future. To support this kind of system, in another way, we need also like the social and economic infrastructure needs, because as I mentioned before, that the problem of the data management and data management is becoming the problem. So especially in the governance context, because like the bureaucratic system is messed up in Indonesia. So it is like needs like the reconstructing the institutional infrastructure design, like reconstructing the new governance model in the healthcare, and before we can actually like disrupting those kind of ideas to be in line together. And the second one is like, it is actually what I said before about how like seeking the common ground about between the universal healthcare principles, maintaining the universal healthcare principle, and also the market system, because health insurance is it's quite high. I mean, like it costs like a lot of money, right? And it cannot be free at all. So we need to we cannot like burdening the national budget for this kind of context. So like we have to understand each other. What is the needs of the healthcare system itself? All the healthcare services for all people, not only for the rich people, but also for people who are actually below poverty line. In this kind of situation, I see that there is a lot of challenges and opportunities. First, like the complexity of governance systems and bureaucratic is actually messed up. Indonesia have like very many like gap in bureaucracy, so it is hard like to understand or like so many level to work on that situation. So we need to like understand about this condition. The second one, because healthcare insurance, I have actually talked also about with Sun Kim, my informant before, that this has actually become the problem for the majority, like the younger generation in Indonesia. I told to her that we have like the low financial literacy rate. It's only like 38%, according to the data of Indonesia Financial Authority. So when my conversations with Sun Kim would be, I'm very angry actually with my friend who actually have higher salary than me, but they cannot actually pay or purchase the health insurance because, okay, this kind of insurance is actually mandatory, but sometimes the mandatory it needs like the awareness of the people to register to the health insurance. But in this kind of context, still many people who are actually not registered on that, even the one who are actually have higher salary, like my friend. But in this situation, why I can say there's like the low financial literacy because they try to like give the proportion to their lifestyle rather than to buy the health insurance. Second one is, the third one is about healthcare sector is always becoming a populist and political tools. You know, in every election year, every candidate try to get their vote to the society by saying that they will give like free healthcare for all, and it is actually become what I say before, the universal health coverage becoming the principle that we won't actually maintain, but somehow it used by the majority of the politicians to chase the voters without rational design to why we should like giving the freedom for all. And the last one is universal health coverage vis-a-vis the privatism, because like the health insurance is basically business, so we need to like maintaining the quality of the financial balancing on this kind of situations. So what is like the opportunities? The technology advancement through data analytics will be the opportunities in the current situations. We are in the technological advancement and disruptions era. There is like AI and machine learning through this kind of situation. So I think it will be like the good opportunity to starting the healthcare technology to solve the problem of healthcare in Indonesia through the technological investment. The second one is about the market demand in Indonesia. Actually, it's relatively high, with 40% of government-sponsored subsidies for those who are actually government servants, and 8% who are actually registered to private insurance, and the last 52% who are actually registered and not registered, or registered or where they register only when they get sick. So it's actually still like the high demand. The third is about the focus on health prevention care, because we still confusing that we don't rely on how prevention care is measured. And last one is improving the clinical services quality, because majority of the clinical services in Indonesia still not really in the standard level in certain region, but in the certain region also they have like get that kind of standard. And the last one, we can use actually the public-private cooperations between the government, the private companies, and also society. So this is actually how personalized health intelligence schemes that I actually constructing. Yep. This is actually the future collaboration that I hope we can do in the future between the government, healthcare providers, citizen, financial institutions who are actually investing to this kind of scheme, and last one the idea. Okay, thank you.